Now I invite Dr. Mahesh Gopala. He's not a stranger to us. He's one of the most prolific retina surgeons in Kerala, and he heads the retina department at Giridhar Eye Care Center. Now I invite Dr. Mahesh Gopala for his talk. Thank you.
So this is one of the topics which is close to our heart. Actually, Dr. Giridhar was supposed to give. He had to go for an examination in PGI. So I am giving on behalf of Dr. Giridhar 3 pearls in the management of PCV. PCV is polypoidal choroidal vasculopathy. Okay. First one is PCV and neovascular AMD, that is wet AMD, is not the same. That is the pearl one. Many of us, for everything there is only injections, then what is the big problem? So it is not the same. Why? Because PCV happens in younger patients, 40s and 50s also, and they lack drusen, which is a characteristic sign of early AMD. And the responses to treatment also is different. Now, the PCV can run a benign course, like sometimes the polyp will be there, non-leaking polyps will be there, and then branching, but it may remain like that for a long time. Only problem with PCV is sudden hemorrhage causing sudden vision loss. Otherwise, it can run a benign course. We need not treat every PCV unless it is leaking or exudation is there. But neovascular AMD with a CNVM usually runs a more aggressive course. Difference one. Then the network also is a little different. In PCV, usually you get a thick choroid or pachychoroid with large halar vessels, and there is no drusen in PCV, and usually the scarring is minimal in PCV unless there is a hemorrhagic complication and resulting in this. So the neovascular AMD on the other side affects the retinal pigment epithelium and Bruch's membrane and choriocapillaries. It's but here the RP gets PCV affected secondary to hemorrhage or exudation. So it's not the primary. So this is the difference between PCV and AMD. And the vessels in PCV have larger vessels, mature vessels, more polyps and branching vascular network, and there is an element of arterial involvement also. So now second pearl is, so how do you know which is PCV, which is neovascular AMD? You look for biomarkers. Even though the gold standard for diagnosis is ICG, many of us will not have ICG. Look for the biomarkers. So these are standard things. Orange nodule in clinical photo. Then that PED, the tubular PED, thumb-shaped PED, sharp-peaked PED, nosed PED, it's a nosed PED, and double layer sign. It is actually a double layer sign, hyperreflective double layer signs. The Bruch's has gone up and there is a, this is separated. So inside that there will be hyperreflective. So hyperreflective double layer sign, and sometime in NHOS OCT also you see that. So these are some of the biomarkers that will tell you you are dealing with PCV along with pachychoroid and pachyvessels. While in CNVM you get these sort of findings, subretinal fluid, photoreceptor degeneration, you get photoreceptor degeneration, hyperreflective dots corresponding to exudates, outer retinal tubulation, SHRM, subretinal hyperreflective material, maybe vascular or then retinal pigment epithelial tears and ribs. So these are all more features, especially in IRF, features of neovascular AMD. Now pearl 3 is go for combination therapy in PCV if possible, not always. Nowadays the standard of care for PCV also is anti-VEGF monotherapy because different studies are there. But I will show one example. This is a case. You can see there is a thumb-shaped VAD with a little hemorrhage, fluid, subretinal fluid, and ICG is showing here there is a bunch of polyps here. You treat with 3 injections. It has reduced, but it is not going. So after that, again do the angiogram. You can see the cluster of polyps beautifully now. Since it is not responding, switch to photodynamic therapy, and with photodynamic therapy it collapses and there is regression of the polyp, and later after few years, 2 years, it starts again. PCV also will come back. It is not that PCV is more curable than NAMD, but you get a space of less injections with PCV if you do a combination therapy. Again new polyps are coming at the edge, creeping polyps. So again repeat PDT and injections, and then it goes. So again it is coming back after 2 years. So in other words, PCV has less aggressive course unless there is a hemorrhagic complication. And if PDT not available now, sometimes in the peripapillary cases you can give thermal laser also, which also will be helping to reduce the number of injections. So these are some of the differences in PCV and AMG and 3 pearls.